and he has also a long-standing experience in ERCP, and he will talk today about quality indicators in ERCP. Guido, the floor is yours.
Thank you, Peter. Very good morning to everyone. We start with quality in ERCP, in basic ERCP. My slide does not go. It doesn't move. Okay. In 2018, the European Society has defined metrics called performance measures with proven impact on clinically relevant outcomes or quality of life and applicable to all endoscopy services. These performance measures for ERCP define a competent ERCP practitioner by setting standards of success and complication percentages to be measured in at least 100 consecutive patients, but if possibly continuously. All the statements made are with low quality of evidence as they are consensus of expert opinions. First PM, successful cannulation of the bile duct. We should be able to cannulate the bile duct via the native major papilla in patients with normal anatomy in at least 90% of the cases, if possible 95% of the cases. Personal advice to reach such high level: take time to observe the papilla. This is very important, and especially be gentle. Go for soft touch. If you touch too hard, you compress the papilla, you will fail and induce pancreatitis. Second PM, common bile duct stones. We should be able to remove common bile duct stones of 1 centimeter or less in 90% of the cases, if possible 95% of the cases, at least in expert centers. Next, antibiotic prophylaxis. We should give antibiotic prophylaxis before ERCP only in selected patients, namely those with predicted incomplete drainage, such as hilar tumors or sclerosing cholangitis, certainly in patients with cholangioscopy procedures and in immunocompromised patients. Minimum standard 90%, target again 95%. There is a little bit of problem because we use frequently quinolones and amoxiclav, and there is growing evidence of resistance to these antibiotics. In this table, in this figure, you see blood cultures taken from patients with cholangitis, and more than half of the cultures were resistant to quinolones. As such, ESGE advises antibiotics active against gram-negative bacteria and to be adapted as much as possible to local epidemiology if available. Next, appropriate stent placement. We should be able to place stents, plastic or metal, in patients with biliary obstruction below the hilum in at least 95% of the cases. And then complication measure, post-ERCP pancreatitis. We should measure the post-ERCP pancreatitis in all procedures. There's a case mix, not only in patients with native papilla, and we should be able to have a level of less than 10%, if possible, less than 5%. Remark, the definition of the ESGE for PEP is adapted from cotton and should include all three of the following elements: new or worsened abdominal pain after ERCP, more than threefold elevation of amylase or lipase 24 hours after ERCP, and requirement of admission for pain or prolongation of the admission. So you should have all three elements to define PEP. Top 5 risk factors for PEP in basic ERCP are especially difficult cannulation, having previous PEP, failure to clear common bile duct stones, and doing ERCP in patients with non-dilated extrahepatic ducts, especially for young female patients younger than 35 years of old. In February 2020, ESGE has updated the guidelines on prevention of PEP, and we will go quickly through the recommendations. There is no doubt that rectal administration of NSAIDs before ERCP significantly decreases the overall incidence of PEP and the incidence of mild, moderate, and severe PEP. And as such, it is advised to give it in all patients if there are no major contraindications. And there are only two major contraindications, namely gestation more than 30 weeks and patients with very severe hypersensitivity syndromes, the Stevens-Johnson and Lyle syndromes, and their first-degree relatives. For an adult, it means about 1.5 liter of colloid in bolus. It's very high. Then third measure, nitrates, sublingual nitrates. They have been shown to reduce the overall PEP incidence to a lesser degree than the other measures, but not that of moderate or severe PEP. And as such, for ESGE, it's the second rescue if it is not possible to give NSAIDs or lactate ringer solution. And then we all know that prophylactic pancreatic stenting in patients with a difficult cannulation, high-risk patients, has significantly reduced the incidence of PEP. And as such, for ESGE, we have to place a pancreatic stent in selected patients with high risk for PEP, namely those where we have inadvertent guide wire insertion of the pancreatic duct, or if we use the double guide wire cannulation, and this is a strong recommendation. We should use a short, small pancreatic stent, 5 French, and remove it after 5 to 10 days if it has not moved spontaneously. Combining prophylactic measures with rectal NSAIDs for the moment is not advised by ESGE, as the evidence is for the moment not conclusive or conflicting, but there are ongoing studies. Important measure to prevent PEP is cannulation technique. We know from pioneering work for Michael Burke and colleagues that we have to go for the guide wire assisted cannulation technique with the sphincterotomy, as this significantly increases the cannulation rate and reduces the risk of PEP. There is probably no difference if you use a standard guide wire or a very small guide wire. We should keep an eye on our cannulation time, because if we go for more than 5 minutes of cannulation and more than 5 cannulation attempts, we induce a high pancreatitis rate of more than 10%. Also, if we have 2 or more unintended pancreatic guide wire passages, 13% of PEP. And these 3 elements are the definition of difficult bile duct cannulation with a PEP risk of more than 10%. In these situations, for difficult cannulation, we switch early to rescue methods. And compared to further cannulation, early pre-cut, especially the fistulotomy technique, significantly reduces the PEP risk, and if done by experts, even so, 3-fold. If you are in a situation where you have a guide wire in the pancreatic duct, proceed with the double guide wire cannulation and place a pancreatic stent. It will also reduce the PEP risk significantly. And in this algorithm, you see the bundling of all the recommendations. You can consult this free online. Everyone has access. A last word, training to become competent in ERCP. Well, some countries have published volume-based criteria going from 200 to 300 ERCPs, but even then we know that not every trainee reaches competence in each domain. As there is a large variation in learning curve, we should probably shift to individual competence assessment, and in the UK they use therefore a validated tool, the DOPS, Direct Observation of Procedural Skills. In USA, a similar formula, the TZAD. I will also mention that ESGE is working on a curriculum for postgraduate training in ERCP, but it has to be published, not yet available.